pituitary function in adult. So for that sessions, I invite Dr. Velayutham. He's a senior consultant endocrinologist at Kobe Medical Center, Coimbatore, and he has many publications in the indexed journals, including the BMJ as well as the JEM, and he was the organizing secretary at the last year Trendo2017 in Coimbatore, and so I invite to deliver lecture on pituitary function.
Thank you, Chairperson, for the introduction, and congratulations to Team Trendo2017. I have nothing to disclose as far as this lecture goes, but I think this disclaimer may be more appropriate now. So before moving further, I think we will just brush up our knowledge on normal pituitary anatomy and physiology. As you can see, pituitary is a peanut-shaped gland situated in a very safe pocket in the base of the skull, the cella turcica. Anatomically and functionally, there's two different components, the anterior pituitary gland and the posterior pituitary gland. Physiologically, we have been traditionally taught as the pituitary gland is the master gland controlling all other, or at least most of the other endocrine glands in our body. This is through various trophic hormones which the pituitary cells secrete, and these trophic hormones are under the influence of hypothalamus here, and anatomically the anterior pituitary is under the control of hypothalamus through the portal venous system, whereas the posterior pituitary is under the control of the hypothalamus through the direct neural connection. So we order a pituitary function test in the following clinical scenarios. Number one is when you suspect there is pituitary hyperfunction, or when you suspect there is pituitary hypofunction, and incidentally detect cellular mass. And the hypofunction or hyperfunction can involve both the anterior pituitary as well as the posterior pituitary. So the posterior pituitary part is mostly dealt by Dr. Murli in the previous talk, so I will not touch upon that. Incidentally detect cellular mass or the pituitary incident lymphoma is already covered by Dr. Satish, so I'll again not go into detail of that. So what I'm left with is mostly dealing with how to investigate or what are the pituitary function tests you do when you have hormone hyposecretion in pituitary. So we start with a clinical case. This is the story of a 40-year-old female who presented with asthenia, dyspnea on exertion for 1 month duration. She was initially evaluated by a physician who diagnosed that she had congestive heart failure, which she didn't have, and then referred her to a cardiologist. So on cardiac evaluation, the echo showed very low left ventricular function, and there was global hypokinesia confirming the diagnosis of congestive heart failure. There was also mild pericardial effusion. So the cardiologist thought, considering the age and the absence of regional wall motion abnormality, ischemic heart disease is less likely possibility, and she did not have any other risk factors for ischemic heart disease. He just started treating her with as a directed cardiomyopathy with digoxin, loop diuretics, and spironolactone. But unfortunately, she did not show any improvement in the symptoms even after treatment for 1 month period. So at this point of time, the cardiologist did a TSH, which was as shown here, 0.09, which is lower than the normal reference range. So he thought there is something wrong with the endocrine system, so he referred for further evaluation. So on further questioning, she had history of amenorrhea for 4 years. She is slightly premature for normal physiological menopause. On examination, she had sallow complexion, puffiness, dry skin. The pulse rate was 70 per minute, which is slightly inappropriate for the degree of congestive heart failure she has. The BP was 100/70 with some partial symptoms. There was no edema because she was on drugs already, and there was occasional basal crackles. And she had a clinical finding on the leg, which I think I will reserve to the last part of my discussion. Investigations showed a normal hemoglobin, the creatinine was slightly elevated, liver function test was normal. So we thought we would repeat a thyroid function. The TSH repeated was again on the lower side of normal, but was not as low as the previous level. But surprisingly, the free T4, which we expected to be high considering a low TSH, was also ground low. the free T4 was 0.19, looking at the reference range of 0.8 to 1.7. So subsequently other pituitary hormone levels were estimated, which showed all other hormones to be on the lower side. So we consider the possibility of hypopituitarism in this patient, causing the clinical manifestations, and an MRI of the pituitary is ordered. You can see this is a normal pituitary gland. Sella turcica, the anterior pituitary, posterior pituitary bright spot. This is the pituitary stalk. This is normal. So compared to this, as you can see that the sella is partly or almost filled by the CSF. The normal pituitary gland is almost flat in the floor of the sella. This is again coronal section which shows that the sella is empty and filled with the CSF. So this gives a diagnosis of an empty cella on MRI. So the patient had empty cella with biochemical features of hypopituitarism. So what are the clinical features of hypopituitarism? Remember that most of the symptoms related to individual hormones can be very, very non-specific and can be deceiving or misleading the clinician. For example, growth hormone deficiency often lacks any specific symptom. They usually have some lack of energy and altered body composition when you just specifically look for it. Gonadotropins in men presents with poor libido, impotence, erectile dysfunction, infertility, and sparse facial and body hair. In women, it usually presents with oligomenorrhea, dyspareunia due to vaginal dryness, infertility, and breast atrophy. So all these, when you can have multiple other etiologies if you look as a single symptom. TSH deficiency can again present with features of hypothyroidism as lethargy, constipation, cold intolerance, dry skin, hoarseness, which I think most of the features were present in the given patient. ACTH deficiency again presents with features of adrenal insufficiency, including lethargy, anorexia, vomiting, weight loss, postural hypotension, and electrolyte imbalance. Prolactin in adults deficiency usually is asymptomatic except in a specific condition, that is the postpartum pituitary failure, where it can present as lactation failure. Otherwise, in a non-pregnant or non-postpartum adult, the prolactin deficiency is of little clinical significance. ADH deficiency presents as diabetes insipidus. I think we have heard from the previous talk. So when you start assessing the patient with suspected hypopituitarism, how do you assess? Maybe the assessment will have to be looking at individual axes involving the growth hormone, thyroid, adrenal, gonadal, and prolactin, which I have been telling previously. Posterior pituitary hormones may be assessed if clinically indicated. So the basic principle in endocrinology is, if you suspect hormone deficiency, you try to stimulate using trophic factors and find out whether there is normal response. If there is decreased response to the stimulation test, we confirm that the hormones are deficient. The same may be applied in the corollary, where when you suspect hormonal hypersecretion, you try to give some factors which try to normally suppress the hormones, and if they fail to suppress, then you confirm that the hormones are hypersecreted. So the assessment of pituitary thyroid axis, it can be done fairly well with the basal hormone levels itself. Usually a T4 level is sufficient. Whether you go for a total T4 or free T4 is always debatable, but a total T4 should be fine, except in few conditions where free T4 may be useful. T3 has its own value except in some limited conditions, especially when you have pituitary deficiency in childhood. You would have heard in the morning lecture where there are a lot of genetic abnormalities which can result in isolated TSH deficiency or the defects in conversion of T4 to T3, where it is in those conditions T3 estimations may be really indicated, and a TSH. So a combination of normal or slightly elevated TSH with low T4 is suggests pituitary failure. So all you need is this set of tests to diagnose TSH deficiency. But sometimes a stimulation test in the form of TRS stimulation to see the TSH response may be required to really see whether the patient is deficient in TSH. But this may not be of clinical importance or really needed in clinical practice for adult patient. And assessment of pituitary adrenal axis, again, basal hormones is quite sufficient, and 8 AM cortisol along with the paired ACTH should do this job. A very low 8 AM cortisol, that is less than 5 microgram per dl, with low to normal ACTH, it again suggests pituitary failure. So there is inappropriate response of ACTH to a low cortisol, which suggests that there is something wrong with the pituitary gland. But again, when the cortisol level is not very low and ACTH is not clearly elevated, then you may need a stimulation test to really assess the pituitary reserve ACTH. And these are listed here. Just to be more a bit more detail on these tests, the gold standard is often the insulin tolerance test, where you give insulin to produce a state of hypoglycemia. The hypoglycemia is a potent stimulus for the release of various hypothalamic factors, which in turn stimulate the pituitary to release the trophic factors. And failure to raise the ACTH levels or indirectly the cortisol to a certain range, it suggests that there is deficiency of ACTH. The CRH test involves the use of synthetic corticotrophic releasing hormone to assess the ACTH reserve in the pituitary. The metilopon test is an indirect test. Actually, what it does is that it blocks the adrenal cortisol synthesis, and this deficient cortisol, it indirectly stimulates the production of ACTH. So after you give metilopon, the cortisol level comes down, the ACTH level goes up. So when you fail to find out a rise in ACTH after metilopon, you can fairly assume that the pituitary is not functioning properly. Still, all these are not available in all centers for routine use. So you may still use the standard ACTH stimulation test, which is commonly done for assessing primary adrenal insufficiency to diagnose secondary insufficiency also. The only fallacy is that you can easily miss out early adrenal failures. Only when the pituitary dysfunction is quite there for a long time, which has caused adrenal atrophy, early pituitary disease can produce a normal ACTH response, which can be missed. And moving on to the assessment of pituitary gonadal axis, again, here a specific stimulation test is hardly needed. We mostly rely on the basal hormone levels. A low testosterone in a male or estradiol in a female, along with the low or normal LH and FSH, it suggests pituitary failure. But here come the GH axis, which is a bit tricky. In contrast with the other hormonal axis, where we mostly rely on the basal hormones to diagnose the dysfunctional pituitary and other endocrine gland axis, in case of growth hormone axis, the basal hormones are quite variable even in normal individuals. So we may not be really able to get a good idea on from the basal growth hormone level or IGF-1 level to diagnose pituitary dysfunction. So it is this hormonal axis which really requires stimulation tests for diagnosis. And the stimulation tests or GH provocative tests, which we call, include an insulin tolerance test, which is the gold standard, combination or individualized stimulation tests, including a GHRH, growth hormone releasing hormone, arginine. Arginine is an amino acid which actually inhibits the somatostatin release from the hypothalamus. The somatostatin is a powerful inhibitor of growth hormone. So when you inhibit somatostatin, it acts as an indirect stimulus for the release of growth hormone. Glucagon, again, it acts as a stimulus to release growth hormone. And often a combination of these tests may be involved in the diagnosis of growth hormone deficiency in adults. And the cutoff, again, is variable between tests, and the standard reference which is used for diagnosing growth hormone deficiency is less than 3 nanogram per ml as far as the insulin tolerance test is concerned, and the same holds good for glucagon stimulation test also. But the other provocative tests, they have their own cutoffs, and remember that the body composition can sometimes alter the normal growth hormone levels. In a normal individual who is obese, when the BMI is more than 30, he or she may have a normal low growth hormone levels, which can produce false positive when you use a lower cutoff. So in patients who are slightly on the obese side, a stimulation test cutoff of 4 point is used as compared to a lean individual where a cutoff of 11 is used when you use the GHRH adrenal stimulation test. And a note on how these hormones deficiencies, the anterior pituitary hormone deficiencies evolve when an insult occurs. And this is particularly with reference to cranial irradiation or following head injury. Remember that many patients who undergo cranial irradiation, not only for pituitary tumors but for other lesions, and patients who have significant head injury, they develop hypopituitarism over a period of time. And this is the normal sequence of hormonal deficiency which happens over a period of time. As you can see that the somatotrophs are the growth hormone, or the cells are the most sensitive cells in the anterior pituitary, which easily gets damaged whenever there is a insult in the form of irradiation or trauma. This is followed by gonadotropes, followed by ACTH. Prolactin and TSH are relatively resistant to the external insults, and they are the last hormones to go. The clinical implication of this is as below. When you find in a patient with suspected hypopituitarism, the TSH and prolactin are deficient, it can never be isolated. It can never be isolated prolactin deficiency, or it can never be isolated TSH deficiency. Invariably, they will have deficiency of LH, FSH, ACTH, and growth hormone. So always look for them, do not miss it. Whereas, in a patient who had a very mild insult, the hormonal deficiency of this pituitary dysfunction may be just limited to deficiency of growth hormone alone. So in adult, growth hormone deficiency can present as a sole pituitary dysfunction as compared to other hormones. But the problems with insulin tolerance test in diagnosing growth hormone deficiency is that though it has very good sensitivity, it has very poor reproducibility. Even in a given single patient, if you repeat the test over a period of time, it may give various results. And close monitoring of the patient during the test is very much needed, so you need a special setting for doing the test. It cannot be obviously done in a OPD basis. And it's contraindicated because of the degree of hypoglycemia the patient gets in patients with established IHD, epilepsy, and obviously in children less than 2 years. So it has its own fallacies. And because of the disparity between the individual GH provocative tests, for example, as I told, in a given patient, if you do 2 stimulation tests, the patient may pass in one test and fail in another test. The typical example is the patient undergoing cranial irradiation. In cranial irradiation, it is the hypothalamus which gets first involved, followed by pituitary at a later stage. So during the initial phase of pituitary or hypothalamic dysfunction, if you do a GHRH and adrenal stimulation, the patient may show a normal growth hormone response. Whereas the same patient may fail to insulin tolerance test, which predominantly depends upon the stimulation of hypothalamus to release the trophic factors. So always in most of the case scenarios, you may need more than one test to diagnose growth hormone deficiency in adult. So the general rule is, if the patient has multiple pituitary hormone deficiencies, for example TSH and prolactin deficiency, it is almost always associated with growth hormone deficiency. So you don't need to seriously do some provocative test to diagnose GH deficiency. In those cases, a simple low IGF-1 levels can be sufficient to diagnose growth hormone deficiency. You may need one provocative test in addition to that. Whereas, when other hormones are normal and you suspect only GH deficiency, then you may need a combination of tests to really diagnose growth hormone deficiency. Because there is always a clinical paradox. Most of our patients cannot afford growth hormone. And the growth hormone therapy in adults, it's really hard to judge the treatment response. We have to mainly rely upon metabolic factors and the quality of life in those patients. So before deciding on whether to start growth hormone or not, it's always better to be doubly sure that the patient is GH deficient by doing this provocative test. So you can always do these tests individually, but a single test again can produce information on all the anterior pituitary hormones, which is the combined pituitary stimulation, where you use hypoglycemia for stimulating growth hormone, TRH, GnRH, and CRH for other hormones. It's just given as a single injection sequentially, and you measure all the hormones subsequently to assess the pituitary function. But again, this is more of done in research setting rather than in clinical practice these days. So to cut a long story short, current biochemical recommendation for assessing anterior pituitary function, we just measure the plasma levels of basal anterior pituitary hormones in most of the clinical condition, and measure the plasma level of hormone produced by the corresponding primary target organ. These two should clearly indicate whether the pituitary dysfunction is there or not. Stimulation tests may be reserved for specific conditions, especially when you suspect isolated growth hormone deficiency. So, hormone excess, I think I'll just briefly say. When you suspect growth hormone excess, you do a suppression test with glucose. When there is failure to suppress the growth hormone with glucose stimulus, you do further testing for assessing growth hormone excess. This is a patient with acromegaly or GH producing macroadenoma with giant tumor there. Prolactin excess is very simple. You just do a prolactin basal level, anything which is high, but you exclude always these factors, potential drugs that can increase prolactin levels. As Satish was telling, a false positive elevated prolactin levels can be due to a lot of drugs. Exclude pregnancy. I still remember a doctor walking into a room with high prolactin levels asking for MRI. You can just diagnose pregnancy at studying it. So there's one more important factor which you need to do when you have high prolactin levels, and ideally should be in unstressed state. This is a patient with prolactinoma, macroprolactinoma, who underwent treatment with dopamine agonists. As you can see there, the beautiful response after treatment of the tumor. These are a cell dissection. ACTH excess, I think it's already been dealt with. Gonadotropin excess is often of not much clinical significance because most of the patients they present with a non-functioning pituitary tumor than a functioning tumor. So back to the patient. The finding I was telling about in the given patient before is this one. So any guess what could be the diagnosis? The etiology for hypopituitarism in that patient. So this is a plastic surgery which was done, or reconstruction surgery which was done for a necrotic lesion there following a snake bite. So this patient had snake bite some 10-15 years back, which she herself forgot. So only when I asked her what was the lesion there in the leg, she came out with a history of viper bite. So this patient had snake bite followed with hypopituitarism. So the hypopituitarism following snake bite is a well-known phenomenon, and it is specially associated with viper bite, which is associated with coagulation abnormalities, and it is more common in patients who have acute kidney injury in the initial phase and significant cellular damage. The mechanisms is always pituitary. We don't know exactly, but there are many mechanisms why pituitary failure develops after snake bite. It can be acute or chronic, as in this case. This patient has been asymptomatic for many years before a diagnosis of hypopituitarism due to a snake bite. Post-traumatic is again another important thing which we should keep in our mind. So management, follow-up thing. So the follow-up after we replaced all the hormones, thyroid and steroids, this patient's cardiac function normalized. She had a normal LV function at the end of 3 to 6 months, renal function normalized, and she's off all cardiac drugs. So the final take-home message will be that the P-sized pituitary gland have a plethora of problems, hyposecretion, hypersecretion, and assessment of pituitary function can be as simple as measuring a prolactin level to diagnose prolactinoma, to as complex as doing a provocative test to diagnose adrenal deficiency. And always remember, non-specific complaints in a patient who had a history of snake bite, for that matter, past history of head injury or in history of cranial irradiation, always think of hypopituitarism, which may require further referral and therapy. Thank you for the patience.
Thank you.